So we're going to get started with some cases in genomics nursing. I love to teach with cases because they make this information a little bit more accessible. This one is adapted from your book. I gave her a face and a name, just a cheesy stock photo. But we will start with Naomi. Naomi is a 31-year-old woman undergoing fertility treatment at the private fertility practice where you work. During your intake, because you were a good nurse and you took a careful family history, you note that her mother, older sister, and maternal aunt have all been diagnosed with breast cancer in the past. What is the nurse's responsibility in regards to this information? So you're looking at your pedigree and you see that these three individuals, two are first degree relatives and one is a second degree relative, have all been diagnosed with breast cancer. Two of them before the age of 40. What is your responsibility? A, report the information to the physician or provider. B, discuss the significance of the finding with the client. C, refer for genetic testing. And D, all of the above. I think you can guess. The answer is D. All of that is within our scope and our role as nurses. The provider needs to know this information before proceeding with fertility treatment. There are cancers that thrive on estrogen. Pregnancy is a state of hyperestrogenism. We could be feeding this cancer if she already has one. The patient also needs to be aware of the increased risk to her. The patient can be screened for genetic markers that are associated with the increased risk for breast and ovarian cancer. You may have heard the terms BRCA1 and BRCA2 genes. They're the famous ones that we can test for. The presence of this gene does not guarantee cancer, but it does greatly increase your risk over a lifespan. And it gives people more options, whether they want to do prophylactic mastectomy, oophorectomy, whether they want to be screened more often with mammograms and MRIs. At the very least, the patient should receive screening to rule out cancer at this time. As I mentioned, a lot of ovarian cancers thrive on estrogen. It's increased in pregnancy. So before you proceed, you maybe want to get this patient screened for breast cancer herself. Referral for testing and consultation with a genetic counselor is appropriate at this time. There may be information that genetic counselor has about the BRCA1 and 2 gene, information that counselor has about testing and what the results mean. And this is a conversation that's going to take a little while to unfold so that the patient has time to understand it and make an appropriate informed decision. Okay, so moving on with Naomi. Naomi meets with a genetic counselor. She goes ahead and has the testing for the BRCA1 and BRCA2 gene. She is positive for the BRCA1 mutation that causes cancer or that is related to increased risk for cancer. So after speaking with the genetic counselor and getting a referral from the physician, she has a 3D mammogram and an MRI of both breasts. There is no cancer. All findings are normal. She asks about screening for ovarian cancer, but is told that there is no reliable screening tool to detect early ovarian cancer at this time. That may change, but at this moment in time, that is true. The genetic counselor discusses the probability of getting cancer over a lifetime. Naomi is told that she has a 55 to 72% risk of developing breast cancer by age 70. So she's got to figure out what that information means. She is told that a prophylactic mastectomy can reduce that risk by 95%. That's a big choice for a 31-year-old woman. And we have concerns about body image and concerns about the options that are left to her with breastfeeding. So she's also told that a prophylactic oophorectomy, that's the removal of both ovaries, is recommended for women who test positive, but it's not recommended until the ages of 35 to 40 or when childbearing is done. Those are big things to have to tell a person when they're 31 years old and they're trying to start a family. So although she's had this appointment with a genetic counselor, she's going to see you again. And you're going to have this information to work with. and know how to support Naomi because you're a good nurse. The fertility doctor is willing to proceed with fertility treatment now if the patient's still interested. He discusses options regarding fertility preservation if she chooses to have the prophylactic oophorectomy. So she could choose to freeze her eggs or have, embryos frozen. He talks to her about the possibility of IVF with pre-implantational um, genetic diagnosis to exclude the embryos that carry the harmful gene. And she's given 3 more handouts and asked if she has any questions. She shakes her head no, the tears are streaming down her face. Now the provider leaves the room and you are alone with her. So take a minute. That's a lot of information to digest. A lot of implications of this finding. How will you help her? What is your role as the nurse? Well, the first thing, you need to have the same accurate information that she has now. She's positive for BRCA1 gene, increases her risk over a lifetime. Pregnancy can increase that risk, but there's a protective effect of pregnancy and breastfeeding on breast cancer. Because while you're breastfeeding, there's less estrogen. Your role as a nurse, you're going to, first of all, support her emotionally and allow her to verbalize her concerns. Remember those NCLEX style questions in psych where they asked you, if you haven't taken psych yet, you'll get there. Like what's the most important thing for the nurse to do? And you say allow her to express her concerns. So you're going to let her kind of hash all of this out. You're going to provide her, reinforce that education that she got. And you're going to support her right to make decisions. If she decides not to get pregnant at this time, if she decides not to have pre-implantation genetic diagnosis, it's your role to advocate for her and support her. And you're going to help her understand how to mitigate her risk factors for breast cancer. Alcohol use in women is associated with increased risk for breast cancer. Low-fat diet is associated with lower risk. More fruits and vegetables associated with lower risk. So you could talk to her about lifestyle modification and her epigenetic factors. And whatever she decides, that's what you're going to support. And of course, you're going to maintain all of her information confidentially in keeping with HIPAA. Okay, so that is Naomi. There's no hard and fast answers. A lot of it is going to happen as it unfolds, but you need to have that basic understanding of her genetic risk and what that means for her and help her make a decision that's right for her based on that information. Cases in genomics nursing, we have another patient and his name is Gary. Gary is a 45-year-old male being treated for depression on a psychiatric floor where you work. Gary has several close relatives who have also struggled with mood disorders. His father committed suicide after several hospitalizations and treatment with a medication called amitriptyline. That's not written here, but just kind of picture it and put it in your overall understanding of where Gary's coming from. He's being treated as an outpatient prior to his hospitalization. He was prescribed fluoxetine, known as Prozac, but he didn't experience any relief and in fact began to experience suicidal ideation. He's read about pharmacogenetic testing and he asks you if this is an option. That's interesting. There is pharmacogenetic testing. We will talk about it more when we talk about the mental health disorders and pharmacogenomics. But you're just kind of going on what you just heard. You're used to helping patients with depression. You have a good understanding of psychotropic medications and other treatments for depression, including ECT, including cognitive behavioral therapy. That's sort of your wheelhouse. This genomic testing is new for you. So you go to the third-year psych resident who is receptive to this testing. He's read about it and he thinks it's exciting. He has training in genomics and he goes to his attending and she says, "No way. This is junk science." How does the nurse proceed? A, defer to the attending physician's guidance. B, instruct the patient to try direct-to-consumer genomic testing after discharge. Hmm. C, advocate for the patient's right to seek genetic testing and customized treatment. And D, tell the patient that you're not an expert in genetic testing. Hmm. I don't know. What do you do? Well, your role as a nurse is to advocate for your patient. You go to the attending and say, listen, I understand that you don't want Gary to have this testing. Can you tell me more about what you're thinking? Don't make it adversarial. Just you're trying to learn more. You are not a genomics advanced practice nurse, but you're curious to learn more about why she made this choice. Might be a complicated choice if genomic testing isn't something commonly done on your floor or in your facility. But there is a variety of pharmacogenetic testing. Some of them are sort of classified as junk science. They provide very limited, useful information to the patient, and the outcomes aren't better. But it is helpful to know what your panel is actually testing. I listened to a lot of TED Talks on this, and I read a lot of articles on it. Even the direct consumer tests might not be all that bad. It depends on what they're specifically being tested for. Most of the good testing now is dependent on testing for a variation of an enzyme that metabolizes your psychotropic medications. It's the CYP450 enzyme. There's a variant of it called CYP2D6. That's not something you're going to see on an exam, but for those of you who are curious about pharmacotherapeutics and pharmacology, it's going to be important to know how people metabolize their medications. We can customize their treatment. So in this scenario, the attending says, listen, I went to a conference. They said the science isn't ready yet. I don't think it's feasible, and the insurance isn't going to cover it. Maybe you're even at a case conference. They have these in psych units and facilities where you, as a team, discuss an interdisciplinary approach to treating psychiatric patients. Maybe the social worker chimes in and says, no way is his insurance going to cover this. So it's shot down again. But the attending physician does agree that the medication's not working, and she switches him to a different medication. It's an SSRI called citalopram or Celexa. This ends up being effective for him, and after a couple weeks, he is discharged home in improved condition. It's going to take a little while for that medication to build up in his system, but he's already feeling improvement in his symptoms. Still, you've been researching this issue and you're intrigued by the possibility that you could improve patient outcomes by incorporating it into practice. And you know the resident's game for this. So maybe the best approach is to recruit the resident to work with you on a literature search regarding pharmacogenetic testing and present your findings to your colleagues, including his attending physician. Maybe find out something from insurance companies about how this coverage could be obtained for patients. Maybe only patients who've been resistant to their first or second line medications should qualify for it under their specific plan. But you could do some fact finding and then present it to your colleagues, as part of a competency day or, lunch and learn, a journal club. There's lots of ways in healthcare that we can improve our practice by just sort of injecting evidence-based care into our collective understanding of how to approach patient problems. Meanwhile, Gary has this testing done through his primary care provider. He emails you to tell you that he found out that he is an ultra rapid metabolizer of drugs that are metabolized with this variation of CYP450 called CYP2D6. It's an enzyme. It eats up certain psychiatric medications. And you find out by looking in your handy drug guide that fluoxetine is metabolized extensively by this enzyme, but citalopram is not, and that explains the improvement in his symptoms, and maybe that gives you a little extra fuel for your presentation to your colleagues. And that is Gary. Do you like these cases in genomics nursing? Well, if you didn't, you probably didn't get to this slide. You shut off my video and found other ways to spend your time. If you do like them and you have the time, I want you to check out this website. There's a link here. If you go to the Google Slides, you can press on it. I'm going to do that now. And there are all these cases. If you are a practicing nurse, you can actually get credit for them. You have to register here. It's free. But there's all kinds of information, and it's really, really good at explaining basic genomic concepts. So with that having been said, I am going to shut off this video. When we come back, we're going to talk about the exciting world of the Human Genome Project and the science that it sparked.